They couldn't do anything innovative or the things that we're going to talk about today, and I asked them why, and they said, well, it's our size. How many employees do you have? 4,000. Okay. 125 employees, you're about to see one of the more innovative plans in the entire state of Florida, and a 67% reduction in claims cost over 3 years.
This was a number that was a total shock to us. Of course, you sit back and you're not used to sometimes these new methods, and you just think, oh my gosh, this is really going to cost us. But with that stop loss in place, they negotiated that down to around $11,000. We had a 67% claims cost reduction, which was a huge decrease in the total claims spend, and a 62% medical PMPM. You hear somebody was sick and they were in the hospital for a week, or they were just newly diagnosed with cancer, and we'd all just hold our breaths, and that's just, it's not there anymore. We don't have to worry about it.
Welcome to Fiduciary.
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it? Today's episode is super special. This is a client case study, someone that we've been working with in the Brevard County area of Florida for at least 4 or 5 years. Donovan and I had the privilege of going to the Health Benefits Conference and Expo through the International Foundation of Employee Benefit Plans in Point of Adra, Florida, January 20th through 22nd. What was really exciting about this conference is we got to host a pre-conference workshop. So this was a 4-hour session where employers from all over the country came in and learned from Donovan and I about how to create a fiduciary framework for their health plans. So this is, again, for their health and welfare plans, how to create a decision-making protocol and essentially a full committee and governance structure around their health plan. So we went really deep into the weeds. That was the day before the conference started, so that 4-hour workshop. And then 2 days later, on the last day of the conference, I got to take the stage with Julia Watt, Director of HR at Medical Technology Transfer, MTT Corp. And this is what you're going to see today, is the conversation with Julia. So it was essentially me interviewing her, going through the year-by-year decisions that she ultimately made to reduce her claim spend by 67%. Super, super exciting. You're going to see really interesting case studies on hospital billing, drug prices. I mean, everything that you can imagine we've seen with this plan. What's really cool about this case study too is that the company is quite small. So there's about 125 eligible. It's probably the smallest client that we have. And there's 85 insured on the plan. So if you were being told, well, you're not big enough to do self-funding, or you're not big enough to focus on your pharmacy solution, probably BS, because this plan is proof that that is not the case. I had conversations, and you'll hear it in the show, I had conversations with employers that have 13,000 employees, 15,000 employees, and they're telling me that their brokers are telling them that they can't carve out their pharmacy, or they can't do any hybrid reference-based pricing models. So listen in. There's some good stuff in this one. I'm super excited to get your feedback. Don't forget to like, share, subscribe. The Business of Benefits with Julia Watt, case study and multi-year planning coming your way. Enjoy. Chelsea Ryckis. I am the moderator of the panel, and I also happen to be the broker consultant for MTT with our esteemed panel guest here, Julia Watt. A couple housekeeping items before we get started. Please silence your phones if they're not already. If you can withhold personal conversations until the break at the very end, this is about an hour, that'd be awesome. And we'd like to make this a little bit more conversational, so if you happen to have questions during, just raise your hand and we can call on you. Otherwise, there is a scheduled Q&A at the end, so up to you how you want to use that. And without further ado, we'll jump right into it. So the session today that you are sitting in is future-proofing your health benefits. So we're going to look at a case study in multi-year planning. Obviously, there's a lot of volatility in
the health insurance markets right now, especially with employer-sponsored healthcare, all of the markets, honestly. So the idea of, and there's a lot of litigation, right? So there's a lot happening with rising costs, but there's also a lot happening with legal risks and liabilities under ERISA with fiduciary obligations. So today we're going to talk through what does it look like to put together a 4, 5, 6 year strategic plan as opposed to playing that year by year renewal game. Something I want to point out before we get started, you're going to hear from Julia Watt here about what MTT does, how many employees they have, their demographics, etc. And you might notice that they're a little on the smaller side. So they're right around 125 employees. I've had a lot of conversations with plan sponsors, actually one yesterday at breakfast, where they told me they were told they couldn't do anything innovative or the things that we're going to talk about today. And I asked them why, and they said, well, it's our size. How many employees do you have? 4,000. Okay. 125 employees, you're about to see one of the more innovative plans in the entire state of Florida, and a 67% reduction in claims cost over 3 years. Now imagine that being applied to a $25 million healthcare spend as opposed to a smaller organization. So I caveat all of that to say, if they can do it, anybody else that has more than 100 employees can absolutely do this too. So it should be inspiring, not, oh, well, they're small and I'm over here. It's the opposite situation. Would you add anything to that?
100% agree with that.
Okay, awesome. So Julia, thank you so much for doing this. We're gonna walk through the year-by-year decisions that you made. As much as I'd love to sit up here and be like, yay, we did it together. Honestly, Julia is the rock star and the hero in this story. She's the one, and just like all of you in the audience, as plan sponsors, you are the real heroes of the story. You're the ones with the power. So you're gonna hear today how she made the decisions every single year, what levers she decided to pull, what was important in certain years as we go through the strategic planning. But let's start first with who you are. So why don't you give the audience your professional background before we jump into MTT?
Hello, my name's Julia, and I've been with MTT for 18 years. I've been the director of HR for 6 of those years, and I also am the director of our medical clinic and wellness center. And my ambition landed me 2 full-time jobs, and sitting up here and talking to you guys today, and has me questioning my life choices, but I'm here at Medical Technology Transfer Corporation. That's the full name of our corporation. We have multi-lines of business. So we do business as University Center Imaging, which is, we have 2 diagnostic centers, radiology centers in Brevard County. We also have L3 Harris Family Medical Center, where we have primary care, urgent care, pediatric care. We have a full service pharmacy, and we have a wellness center that has mental health services as well. And we also have a shared partnership with Bridgeway Billing Solutions, where we offer medical billing on top of that.
So tell us a little bit about your employees, because it's a bit unique. So up there it says 85 employees, that's benefit eligible. You actually have how many total?
125.
That you're managing, okay. So dive a little bit into the demographics of those employees and their job titles and where they live and all that.
Yes, most of the employees live within our county, and we have about 104 of those employees are all females. We have about 25 males, 26 males, so not very many males compared to females, so they are typically the ones choosing the benefits, and they know more about benefits. Females tend to go to the physicians more often than males do. Just looking at that from our medical center side, we see that more prevalently. And when we were able to get the information and the transparency, we were able to see that as well.
Yeah, it was proven.
One
thing I would add, out of our book of business, we have a lot of different industries. MTT is one of the smaller employers that we work with, but one of the most highly educated consumers of healthcare that we have. in the entire book of business. And obviously, given what their industry is, it makes sense, right? And then we know that females generally make over 80% of healthcare decisions within a household. So the nice thing about this versus the rest of our book, which tends to be very male-dominated, is we get to speak right to the decision makers during open enrollment, which are the females, as opposed to trying to, wrangle the men. All right, well, let's go ahead and get into it. So in 2021, tell the audience where you were, how you were approaching renewal decisions, and kind of what your reality looked like at that point.
Well, at that point, we were, working with a broker that would give us, renewals every year, and we would try to negotiate it down a few percentage points. And then in 2021, we had a 10% increase, and we tried to absorb that for our employees. And then we typically would have about 3 to 4 plans that we would choose from, different insurance carriers, and then we would just pick the least worst option of those 3 plans.
The very first conversation that we had, I remember asking about the 5-year historical trend, right? Like, so if it's 10% this year, what was it in the past? Because I recall that 10% wasn't actually, scaring anybody. It was like, oh, we're doing pretty good if it's 10%, right? And how many of us in the audience have heard that before? It's like, oh, if you have a single-digit increase, then you should be happy, like you did something great. A lot of that, especially if it's not proven with to-the-penny accounting claims data, is just, it's one of my favorite terms in the industry, smoke and mirrors, right? Let's get everybody to look over here when the real problem is over here. So I know one thing that stood out to me in our conversation was when I asked, what's been the plan, especially before you were making the decisions as director of HR? Yes. You said the company just kept absorbing increases because they didn't want to pass it along and upset employees.
Yes, correct, yes,
Yeah.
That was the plan. So we were trying to do that, make that work, and in 2022, that was
not going to happen.
Not going to happen at all. No.
So you were fully insured with a really large carrier here in Florida.
Yes.
And then 2022 came where there was a 45% increase. Walk me through like the C-suite conversations. Like, did you ever bring it to that 45%, or did we get involved sooner? You did, okay.
Yes.
And what was the reaction? Was there like an understanding that, oop, this isn't going to work, or?
Yes, that was not something we could, just negotiate down a bit. This was a number that was a total shock to us, something that we weren't prepared for, and we couldn't absorb those costs and then also put them onto the employees, because it's just, we have other healthcare businesses right down the road that could offer better benefit packages, and our employees might not stay. They might go, and we could have retention issues at that point.
Right. So when you were given the 45%, what was the rationale?
Well, we just had some high-cost claimants that year.
And did you have any, actually I remember specifically this renewal package because it just sticks out to me, but tell the audience how much information you had.
Well, we just had overall PMPM per member per month, and just the total cost of claimants. No diagnosis, no nothing behind, no data, no pharmacy, nothing. Just this was the cost. You had high cost claimants.
The other thing that was interesting about it is it was on one page, right? So imagine, hey, your rates are going up, quite literally going to almost double, but here we are, and here's one page of accounting and detail for you, right? That's a problem. And then on the page, what was the most interesting to me was when we got involved and started having conversations, the numbers that were shown for these high-cost claimants, it's what was billed, not what was actually paid. And a lot of the times, I don't know if everyone's familiar with that, but if you were working with a carrier, right, and they're the ones in charge of the data, you don't actually have to-the-penny accounting, but you're getting reports from them. You have to remember that a lot of the times, those reports are going to tell you the story that they want it to tell you, right? So there could be a $1 million claim on there, but they actually paid $300,000 for it, but you're looking at it like, oh my goodness, $1 million, thank goodness we had this protection, right? So a takeaway, if you're only seeing limited data, make sure to ask when claims data is charges are being put in front of you, is this what was billed or is this what was actually paid? because you'll be surprised how many times they're showing you billed versus paid, and you'll have some negotiation room there. Okay, so 2022 was like, uh-oh, we're in trouble, right? Yes. So talk me through what made you realize that there was other options out there, and like, how did we start this conversation?
Well, I think that was a turning point to say, okay, what else can we do? This has to change, and that really made us look in you to give us the information to look elsewhere and how we can actually make a change. We felt like we were in the movie Groundhog's Day. Every year we would go through the same things. We'd get the renewal, try to negotiate it down again, and then we would just go through the cycle over and over again. It just wasn't
like not
working.
solving any real problem, right?
No.
I see a few of you were in the workshop that we hosted on Tuesday. There was one really big takeaway. So when you get to your renewal conversations, whether you're fully insured, level funded, self-funded, it doesn't matter. The conversation needs to be not, help me hop from this carrier to this carrier, or what are the deductibles, what are the annual premium? The conversation really needs to be around how do we impact the frequency and the severity of claims? Because she was told you had bad claims. And how many of us in the room have been told you had a bad claim year? Probably everybody at some point, right? So the claim, or how about this one? This is my favorite. The claims are the claims. Has anybody heard that? Yeah. There's a distinction between the claims being the claims, and what people are really meaning when they say that to you is the conditions are the conditions. So for example, you're gonna see here, we had a pretty high cost drug on the plan. Are we paying $80,000 a year for that high cost drug? Or are we paying $11,000 a year for that high cost drug? Are we paying $100,000 for a C-section, or are we paying $15,000 for a C-section? A claim is a request for dollars. A claim is not a condition. So we're not saying, your employees shouldn't have cancer, your employees shouldn't have babies that end up in the NICU, your employees shouldn't have dialysis. You cannot control conditions, but you absolutely can control claims, which is the request for dollars associated with that condition. Does that make sense? Okay, because that's one of my biggest pet peeves is when I hear, oh, well, we got an increase because we had really bad claims, and it's like, do you know what you're paying for those claims? No, we have no idea. We were just told, and it's kind of blind faith. So the whole idea of creating a 5-year strategy is getting enough insight into the plan and designing the program in a way that when you see these high cost items come through, you actually have the power to do something about it. Right? So we're going to talk exactly how that was done. Any questions so far with the catalyst of the big number? One thing I'd add is a lot of the times we do see that big increase is what initiates change, because money talks. But I want to make it super clear that if there's years where you have a minimal increase or a flat renewal or even a decrease, you have so much dang leverage. I would absolutely use that. It's super easy those years to be like, easy button, renew as is, yay, no changes. You're giving up all of your power. Even if you just go to market, get more competitive options, and then renegotiate with your current, don't assume that a flat or a small increase is actually in your best favor, because especially if you're working directly with a carrier, their fiduciary responsibility is to their shareholders, it's not to you. So make sure that you're using those good years, push it even harder. Like there's so much more you can do on that. Okay, so let's talk through exactly what we did. So in 2022, what decision did you make after that 45% increase from Florida Blue?
Well, at this point, we were able to go from fully insured to level funded at this point. So it wasn't a flip of the switch moment. It was something that was strategic, and we planned it out step by step.
The difference between, and I apologize if everybody knows this, but I just really like to make sure everyone's on the same page foundationally. So fully insured, my husband always says this, he's like, it sounds like a warm blanket, right? Like, it's like, oh, that's nice, like there's no risk. And self-funded sounds absolutely terrifying, right? The way you want to think about it is fully insured is basically you have that annual premium, and whether you perform really well or really crappy, that's the annual premium, it's gone, right? And think of it like a closed box. Generally, within the box, you have a TPA, that's who's paying and processing claims. You have a pharmacy benefit manager, that's determining the price of drugs. You have your actual insurance, which is stop loss, and then you have a network, generally. Most plans have those 4 pieces. In fully insured, the carrier owns and operates all of them, and because of that, they can call the product confidential, and that's where the box is closed. So you don't get to look in, you get to see what they want you to see, ultimately. When you go level funded, it's a little bit different. You're funding claims, right? So you were obviously funding claims in your fully insured, but you're just paying that monthly premium and you don't really know where it's going. I can tell you at least 40% of it is generally going to claims, some is going to admin, some is going to all the other things, insurance, etc. In level funding, you would get the breakdown of where that premium is actually going. How much is going into a claims fund? How much is going to admin costs? How much is going to stop loss insurance? And you're basically pre-funding the claims account. And as claims come through, they're drawn out from that claims account. If you have a great year, which right now we're at a 67,000 surplus, so, and I don't want to steal your thunder because I know you've got great results to share, but if there's a surplus when you're level funded at the end of the year, the company can retain that as long as it's written into the contract. And there's a lot of carriers out there that will be like, you get your surplus back. And then you read the contract and it's like, actually you have to renew. You get it a year later if you're still a client and you're only going to get half. So if you are in any level funded arrangements or you're looking at that, I highly recommend to look at the contract terms around that surplus payout. But nonetheless, self-funded would then be you're actually paying claims as they come in. You're not level funding into an account and the claims are coming out of there. You're paying claims as they're incurred with a max. That's your stop loss insurance. So it could be $75,000 per individual. And then you have another layer of protection on top of that, which is your max exposure for the year. So that's the difference in those 3 plans. Apologies if everybody knows, but I think it's helpful to know what we're all talking about. So the step wasn't, okay, we're with Blue Cross Blue Shield, let's jump self-funded and learn all this new stuff and create a custom healthcare plan. The idea was, how can we take it slow over multiple years? And then as things came up with our level funded plan, we could talk about, okay, 2 years from now, this is how we would handle this exact situation. Are you comfortable with that? How that would work? And Julia would be like, yeah, I am, or no, I'm not. Okay, so we ended up with a signal level funded option, right? And what was the big reason that we chose to go, or you chose to go that way?
Well, we were able to get the data and the visibility into what was actually driving the costs, and that made the impact to make our changes. Without that, we couldn't decide what to do. Right. So we really needed the data visibility to do that.
And she has a really good point. It is pretty tricky to go from fully insured to true unbundled self-funded because you're not getting your claims data when you're fully insured generally. And a lot of stop-loss markets aren't willing to take a chance on a blind population from an underwriting perspective. So having that level funded, so remember the closed box of fully insured? Level funded is basically like, we're gonna open half the box. We're gonna let you peek in. You can't actually do anything about it. So for example, we'll talk through when we were with Cigna, we had a high cost drug and we're like, hey, we know we can source this, actually through a vendor in the room. We know we can source this for a fraction of the cost. And Cigna's like, no, you gotta use our specialty pharmacy because we're getting the rebates. So it's cool that we could see the drug, but we were still handcuffed. Ultimately, and but that's okay. Like that was part of, we knew that was the plan and that was what was going to happen. So it's all about data, right? And then let's keep going. So 2023, what did we do?
Well, we were able to go self-funded at this point, and we were able to manage our top cost drivers, and we were able to source out those pieces, have the stop-loss protections in place, work with the PBM, USRX Care, and source those medications internationally.
Yeah, so that kept being a theme. It wasn't necessarily, yes, absolutely right. But it wasn't like For her female population, we generally expect that pregnancies, child deliveries, a NICU baby, like that's going to be one of the top claimants. And it wasn't. It was high cost drugs. She had a drug problem, folks. So that's where the focus needed to be. And again, when we would go to the carrier at renewal and say, or actually we would identify, so our team, our account executives look at these reports every single month. And we see what's going on, we see what's being filled, and we're always looking for different ways to maneuver and reduce cost. And unfortunately, when you're in that half-closed box, again, they're not gonna let you do a lot of the things that you wanna do. But the good thing is we got our data and we could see that you were an amazing candidate for a true self-funded program because the claims weren't that bad. The claims that were so bad, by Florida Blues standards and other people's standards, they weren't. So in 2024, we took it even a step further.
Yes.
So that was when we went from that level funded arrangement to a true unbundled.
Correct.
So talk to me a little bit about that.
Yes, well, at this point we weren't guessing. We were prepared and we had all the protections in place and we're able to really manage the plan at this point and look at it from every area that is causing these high costs.
So as an HR director that, you had pretty good autonomy. The nice thing with MTT is they really trust you, as they should, to make these decisions, right? How did you decide that pharmacy in 2024, because that's really where we set our sights, how did you decide, not only from a cost perspective, but let's talk member experience? Like, was there a reason that was the first thing that you did?
Really, the cost was driving it, and the members wouldn't feel any impact, really. They would still be able to fill their medications. They could still get them delivered to their home if they wanted to. Nothing changed for them in how they got their medications. Their insurance card never changed. Everything was the same on the card. Like, they didn't have to have a special card for it.
Right.
It's very easy.
And it's happening in the background. That's the brilliant part about really focusing on the PBM within the health plan and starting to make changes there is, to Julia's point, nobody knows. We are the only ones that know that instead of working with Express Scripts or a conflicted PBM that's taking a giant spread on every single drug that we fill, we're working with what's called a Fiduciary PBM. That's a PBM that just charges a flat fee, and rebates are passed through if they're negotiated at all into contracts. Everything is done with the intent, the best intent for the plan sponsor. And I can tell you, and I know that every time I say this, I know people are like, oh, that's a little aggressive, but it's the truth. The way that employer healthcare plans are designed traditionally is to, everybody in the healthcare supply chain profits when employers pay more. And when employers believe that the claims are the claims, when employers believe that there's nothing they can do, when employers believe there's only 3 or 4 options, guess who makes more money? Literally everybody telling you to believe that story. And as you can see with Julia, and we'll get into it more, there's a different way to approach it with long-term planning and long-term strategy that gives you real power, and you don't have to be that victim. But if you're being told over and over again that there's nothing you can do, generally it comes down to misaligned incentives. Hospitals make more when employers just renew as is. Obviously carriers make more, brokers make more, every PBMs make more. If you look at the entire supply chain, that's exactly how it works. Okay, so let's go into you chose to go to an independent TPA. So in 2024, remember those 4 pieces of the health plan, they were once being run by carriers, all of them. Now Julia decided, let me see how the market really works. Let's have 30 or 40 vendors compete on each part of the health plan. So we went and did a TPA procurement, looked at dozens of TPAs. That's the third-party administrator that's paying and processing claims. We looked at dozens of PBMs we have a 60-point PBM procurement process. So you're really getting into the nitty-gritty of who's actually serving me. 30, 40 stop-loss markets, right? And then the network was the really interesting piece that we kind of ended up, I wouldn't say having challenges with, but if there was any roadblocks in the plan, that was probably where it was at. So the idea was in 2024, we're going to go independent, like truly, truly independent. We're only going to hire vendors that are aligned with the plan's best interest. And so talk me through some of the decisions you made on the stop loss side too.
Yeah, so the stop loss specifically, I'll start with that. This really was something that was also important to be able to have a way to negotiate claims down. We weren't able to do that previously, for somebody to actually look at the claims data and be able to change what was just thrown at us at a $100,000 or more hospital visit. We weren't able to even look at that data that they were providing and saying that we needed to pay. So now we could do that. We had somebody who could then negotiate that down a bit. So that really helped there.
I'll add one thing to that. So with like a Cigna level funded program, or when you're working with a carrier that, even if you're level funded or self-funded, right? I talk to plan sponsors all the time and they say, yeah, we're self-funded with Blue Cross or whatever. You are, in theory, but it's called ASO, Administrative Services Only. And ultimately, that arrangement doesn't allow for the same type of flexibility that the arrangement that Julie is in right now. You're not allowed to audit claims generally. You couldn't outsource the PBM because there's way too much profits in that. There's a lot of restrictions within an arrangement like that. One of them being, I can't tell you how many times I look at an ASO proposal and the stop loss, it's not funded appropriately. The claims funding isn't appropriate. So you look at the population and they're like, oh, okay, we expect, I'll just throw a number out there, like 7 million in claims this year. And then our team's looking at it and it's like, actually, we're expecting like 10.5. What's going on here? A lot of the times there's an intent to underfund the claims fund so that, and then everything looks really good, right? Because you're paying for less insurance. But the next year is when you get hit. The next year is when it sucks. And they're like, oh no, you had a bad year. And it's like, no, we didn't have the proper claims funding. We didn't have the proper stop loss. Our spec was too high, our spec was too low, whatever it ends up being. So something that was really interesting is when we, in 2024, did an independent stop loss analysis, we actually increased the amount that the company would come out of pocket. And it worked really well for you because what was the reimbursement the following year?
It was $120,000.
For a company with 85 employees. I mean, imagine that with 10,000 employees, 15,000 employees, what that return would be if it was designed and managed appropriately. So, but that was Julia. Julia's the brilliant one there that had us looking at all of that. Okay, so that was, and then the result, guys, was a 25% cost differential off of the Cigna renewal when we went unbundled, which was great. I will add one other thing. Carriers, obviously, and I'm sure there's some here in the room, there's this whole idea of like carrier loyalty, right? I got an email yesterday. We have another client that's in this exact same predicament, so they are on year 2. And this happened with you too.
Yes.
So year 2 of a Cigna level funded program with the intent of unbundling and continuing down the transparency pathway. The email I got yesterday was they hit this company with a 40% renewal increase. That is absolutely not justified. We have competitive market data. They do deserve an increase. Their claims were pretty terrible, but it shouldn't be that. It should be like 16, 17%. And then in future years, we'll be able to do a lot more when we can actually control the PBM and do all the things we're doing with Julia. But this is one of those kind of like transition years. The email from Cigna said, Ethos Benefits has a history of moving clients when they're given double-digit increases. We don't consider this a long-term partnership. We'd like to have a conversation with Ethos Benefits about your carrier loyalty and your basically like lack of ability to encourage your clients to just take increases. My response was, that was a very gross email. I encourage you to reread it and tell me if you feel gross after you read that, because I feel gross. And I work for the plan sponsor, I don't work for Cigna. And they are fiduciaries to their employees, and they have a fiduciary responsibility to not pay 40% more if there's other options on the table. So if you can do better, and if you can't, then the conversation ends here essentially. But it's gotten to the point where carriers are threatening to strip our ability to do business with them because they're like, oh, well, we know you're going to do what's best for them. So, it's the Wild West. It's a little crazy. So be, weary of the idea of loyalty, because your loyalty as a plan sponsor, literally the duty of loyalty under ERISA is to your employees. It's not to the carrier. So hopefully you're not in that situation, but they did it to you too.
Yes.
Yeah, they were not happy. Okay, the other thing we did that we haven't talked about is reference-based pricing. Do you want to touch on that?
Yes. So with the reference-based pricing, we were able to have a PPO network and offer, out-of-network benefits. We didn't just have an HMO as well. This allowed us to have a better reference point for the prices and charges that we were receiving and control those costs.
So we didn't want to shock employees with reference-based pricing out the gate, especially highly educated consumers like that. They definitely need more education. Everybody needs more education on reference-based pricing, really. But so the plan was, let's use a PPO network for physician services, and let's do a hybrid reference-based pricing on certain hospital charges, not a facility, not every single one. So there's 5 of them. I was going to read through what those were. So we set these limits with the TPA, and we said any charge for ambulance services exceeding $2,500, inpatient hospital charges exceeding $10,000, infusions above $1,500, outpatient surgeries $2,500, ambulatory surgical centers $2,500, and physician charges exceeding $5,000, and all kidney dialysis. Those specifically were subject to reference-based pricing. Reference-based pricing is where you use Medicare. Medicare is the largest insurer in the country. Hospitals make a ton of money off of Medicare. A lot of them will tell you differently, especially nonprofits, which is comical. But the whole idea is the starting negotiation is 120 to 160, sometimes 200% of Medicare. So if Medicare is going to pay $17,000 for that knee surgery, we're going to offer 200% of that, which is pretty fair. I mean, 200% versus, $300,000 or whatever crazy amount is the PPO discount that you're getting. So Medicare is just using, or reference-based pricing is just using Medicare as that reference point. You build in a margin on top of it, and then that's where negotiations start. And we're going to show you some pretty crazy examples of that. Because what's really interesting, if you think about it, every single one of us can walk into the exact same hospital with the exact same condition. I bet none of us pay the same amount at the end of the day, right? It's a claim. It's a request for dollar amounts. So that's how you can control what you're paying when it comes to the network. It's reference-based pricing. So how did that work? Because how many of us in the room have heard like, ooh, RBP's scary, employees are going to be mad, there's going to be a lot of noise. Has everybody heard that? Yeah. Okay, that generally tends to be the narrative around reference-based pricing. There's a few reasons for that, but I'm curious with your, I don't want to say needy isn't the right word, but high touch population, the white glove expectations, how did they handle the RBP hybrid model?
They honestly didn't know anything about it aside from that their claim took a little longer to get paid. So they didn't feel any of those effects at all.
Yeah.
They didn't know that it was really even happening behind the scenes, and it's
yeah, that's
amazing.
The power of the hybrid model, though, because if it was every single hospital claim that was being negotiated, that will inevitably cause some disruption and some noise, and there's a million things that not you, but hopefully the team that you're working with can do to make sure that we're intersecting the employee before the point of friction. That's the key. If anyone's considering reference-based pricing, you want to make sure that you're working with somebody that understands where the friction points are and how do we intersect just like a day or two before that friction point. That's the key to reference-based pricing from an employee member experience. But the hybrid model is great because we're really only focused on, 5 to 7 specific charges. We can educate the plan sponsor on how it works, so it's not just like trial by fire. All right, let's go into what the plan looks like today. Do you want to go through it? Oh, you can't see it. Okay, so we have a TPA who I'm hoping is not the one we're with forever, but nonetheless, and the claim repricer. We've got that PPO network, and then we've got the actual stop loss. That's the core medical and the risk component. On the pharmacy side, we have a transparent fiduciary PBM. Quick note, be wary of pass-through, transparent, even the word fiduciary. If you were in my workshop, you heard me say this, it's getting watered down. Anybody can market that they are XYZ, everything comes down to contract language. So when you're exploring new vendors, request a copy of the agreements and look for certain phrases like confidential, proprietary. Look if they're willing to take on fiduciary status along with the plan sponsor. That is the key with the PBMs. If they're not in your best interest. RX Manage is international sourcing, so this is where we were getting these drugs, as you'll see here in a second, from tier 1 countries that have higher standards than the FDA. The exact same drug from the exact same manufacturer, just sourced through legal pathways. There are illegal pathways and there are legal pathways, and that has significantly reduced cost. Canada, the UK, New Zealand are those tier 1 countries. And the amazing thing about it is we designed the plan so that employees get that drug at no cost. So they're highly incentivized to utilize the mail order international pharmacy. And that's another thing that I would say is whenever you're looking at, okay, I want to do this over the next 3 years. If you're going to roll out changes, we all know employee populations pretty well in this room. If you're rolling out a change, it's automatically perceived as a negative. It could be the best thing in the world, but they're just assuming because healthcare sucks in this country. And so often they get told, it's costing more and your deductible's going up. But don't worry, we have a high deductible health plan with an HSA that you're never going to use and you have no idea how to use, and be a good consumer, right? And someone's living paycheck to paycheck. Like, it's a joke. They've had such a bad taste in their mouth that when you bring a change that's good, like we did, it's still, there's suspicion behind it, right? So if we know that they're going to be suspicious of any change, we want to try to bring those changes in good years, and we want to try to bring those changes with a lot of pros. For example, with other clients, we have direct contracts with cancer facilities where if somebody, God forbid, is diagnosed with cancer, their treatment's at no cost. Free child deliveries, things that build morale, and you can do that when you're not paying 6-7 times what you should be paying. So that's what we did with international that helped. And then on the member experience, what's not pictured here is our internal account management team that does a lot of text messages out to employees. So we have proactive text message campaigns that seem to be working really well. And then if a member is experiencing a point of friction, they just text the account manager. They don't even go to Julia anymore because Julia's not going to fix it fast enough. You'd come to us and we go through the chain, but why not just go to somebody that can fix it immediately? So then our team picks up the phone, calls the provider and says, hey, you actually do you accept cash? Do you like to be paid? Do you want to be paid faster than the PPO network? Let's do it. And then you have Teladoc, and then this is really cool. So because they're healthcare facilities, do you want to walk the audience through what you decided to do with like direct contracting with yourself with imaging and primary care and all of that?
Yes. So for a few years, we have been offering our employees, a stipend to be able to get imaging services within our facility. And then we also, last year, which I'm very excited to see the results in our PMPM this coming year, they are able to use our clinic, our wellness center, at no cost to them. And it's a reduced rate fee schedule that is billed to our insurance plan, which helps us on the back end as well.
So she's essentially direct contracting with herself, which is actually easier for the employees because they can utilize the services at any time, right? They don't have to take time off of work to go and do it. It's working out really well. I'm super excited too. And generally what we see, so you can kind of compare this, it's not the same thing, but in theory, like direct primary care, right? There was a session on that with Hint, they're amazing. Direct primary care is a fantastic solution. What it does is it generally will reduce ER visits by 30 to 40% first year, and that every single time we've done it, that has been what's happened. So I anticipate that something close to that with you, maybe a little bit different, but.
Yes, and then we also offered our employees out-of-network copays on certain types of visits as well, which also helped.
Because there was some disruption with the PPO network that we chose, because they went from a Cigna PPO to, we did First Health. And I think the disruption report showed that there was a handful of people who happened to be the louder people. Yes. So Julia's remedy to that was, well, let's just improve, and this is what you can do when you can control your plan design. Well, let's just make an amendment to the plan and we'll increase the out-of-network benefits. And then they stopped complaining and everything was fine. And those are the types of things that you can do when you have control. So that was really creative. Do you want to walk us through this one? So this was our drug problem that we had.
Yes. We had one of our large drug costs was the Humira, and the cost per fill was around $6,000 that they were getting a few times a month. So it was around $14,000 to $16,000 a month that it was costing us, and annually over $84,000. With the international sourcing, we were able to get the same medication at a lower rate and no cost to the employee, and we were able to save over nearly $50,000 just on this one medication. We had other medications as well.
Yeah. And the same as for GLP-1s, if that's a big cost driver on your health plan, a lot of those can be sourced for significantly cheaper. And remember, this is a smaller company. Think about this for 10,000 employees, 20,000 employees. It's huge. And again, the employee receives the medication at no cost. That is a key point. Where international pharmacy can become a little sticky is if you mandate it, depending on what state you're in. So certain states will allow for that, certain states won't. So as long as you're not making it mandatory, usually the pathways are okay. All right, let's talk through an outpatient hospital example. So remember, we had it triggering, we had the claims reports triggering for anything outpatient over 2,500.
Yes. So we had, one of them was a patient or an employee that went to the hospital, and the bill charge came back. We saw this claim, it hit our high cost claim alert and showed that it was $101,000. Of course, you sit back and you're not used to sometimes these new methods, and you just think, oh my gosh, this is really going to cost us. But with that stop loss in place, they negotiated that down to around $11,000.
Yep, so that's that Medicare, right? So the hospital was like $101,000, and then the plan was like, no, we're not going to pay that. We're going to start at, I think your plan is 160 or 180% of Medicare. We're going to start at this rate, and we'll start here. And they eventually came down to $11,000. And I have seen this over and over again on much larger claim amounts. So this is the repricing function. This is the reference-based pricing function of the plan that's saying, let's actually look at this. The other thing to consider above Medicare and that reimbursement is errors. I hope everybody knows, but 80% of bills have errors. And you're being charged multiple times for things. So it's always important to get the itemized. So we have this saying, never pay the first bill. That's actually, there's somebody in our industry named Marshall Allen. Unfortunately, he passed away a couple of years ago, but he was a reporter, like a forensic reporter on healthcare, and he had this terrible journey with healthcare billing and almost went bankrupt because of it. And he wrote a book called Never Pay the First Bill. And we use that as a way to educate employees, like never pay the first bill, give it to our team. The team will negotiate it down every single time, 80% of the time, right? Also, to note on that, as plan sponsors, if you're subject to ERISA, you have a fiduciary responsibility to your plan beneficiaries to monitor the costs, monitor the vendors within the plan, pay only reasonable fees. You can't do that if you can't see things like this. And that's not to say you have to go reference-based pricing, but it's just to say if you're not seeing data, you definitely want to. So the plan avoided more than $90,000 in billed charges. And with a plan this small, the conversation next year in a traditional model would have been like, ooh, you had a hospital hit, that was really bad, sorry, here's your increase. So this is what I mean when I say, how do you control the frequency and the severity of the claim? What are we paying for that hospital visit? What are we paying for Humira? So here's another one. This was actually just recently in August, and this was under the PPO. So this wasn't even under reference-based pricing. So this wasn't a Medicare repricing situation. This was simply, the bill was so wrong that when our team looked at it, it started out at 120. There was charges that were ineligible. There were charges that weren't covered by the policy at all. There was multiple duplicates. And when we applied the PPO network discount, $6,000, but the final amount paid by MTT was $7,000 from 120. And most of the time, health plans, it's like it's a credit card. It's just operating in the background. So that was. I guess my point here is you don't have to be reference-based pricing to impact the cost of care. All right, so let's talk results. Walk us through the results of your 4-year path.
Wow, so like we said before, we had a $120,000 surplus that we were able to reinvest into our plan for the following year to cut costs. That we had a 67% claims cost reduction, which was a huge decrease in the total claim spend, and a 62% medical PMPM per month. So that was amazing, and I'm very excited again with the out-of-network and within our facility to see this really drop even further. I'm very excited about that.
Too. The other thing that was super impressive was the 76% RX per member per month.
Pharmacy claims, it was amazing.
Right?
It's huge.
$253 per member per month is what the plan used to pay towards pharmacy costs. Now they're paying $61. In our entire book of business with groups across the entire country, the lowest company is paying $37 per member per month. We've got one around like the 50s, and then it's you, and then everybody else is like 60 to 80. But you guys are absolutely crushing it. That is incredible. And that's again because she is working with a fiduciary PBM. She's sourcing drugs internationally. She's being intelligent about the formulary and the plan design. And you only can make those decisions when you're in a plan and a program that allows you to kind of make those decisions, right? So again, we have our primary care. We direct contracted with ourselves to lower costs for employees and for the plan. She enhanced the out-of-network benefits. And then the best part of the story is for the last 4 years, there has been no increase to employee cost or premiums, and care has only gotten better. Coverage has only gotten better every single year. So for 4 consecutive years, Julia hasn't had to go to the team and say, sorry guys, healthcare sucks, because she's doing such a good job in managing her program. So where is the program today? I know you met with your Ethos team last week. How are you performing? How's it going?
It's going good. We're around, I think it's around 67,000 in surplus. Right now we're sitting really well. We do have a few other high cost claims, not nearly as high as this previous one. So I'm excited to see how that gets negotiated down, and I don't worry. We don't worry like we used to. We hear somebody was sick and they were in the hospital for a week, or they were just newly diagnosed with cancer, and we'd all just hold our breaths, and it's not there anymore. We don't have to worry about it.
Right. And something that's neat is every year we have the ability, because we have to the penny accounting, we can see every single pharmacy and medical claim. If we start to see trends, which we'll look for, we can actually do something about it, right? Like this isn't likely for your population, but let's say diabetes, GLP-1 usage goes through the roof. You tend to see that a lot with male-dominated industries too, or heart disease, cardiovascular, musculoskeletal, right? Which has a whole other issue with opioids and things of that nature. If you start to see these trends in the claims data, you can actually do something. We could put in a GLP-1 protocol or a diabetes management program. If we start to see a lot of oncology claims, we can strategically direct contract with cancer centers across the nation. We can put in an oncology management program. You can do stuff when you know what's actually driving cost, and not just the billed charge, but you actually can see what's being done day to day. So the really cool part about this is that they reinvested it back into the member experience, which I always love. So kudos to you. You've done an incredible job. It takes a lot of courage to think differently and bring it to your C-suite. Speaking of bringing it to your C-suite, obviously the feedback from employees has been pretty positive.
Yes.
I asked Julie at breakfast today, I'm like, what's been the worst part? And she's like, honestly, what did you say? There wasn't really, other than a little bit of the network disruption with that first PPO.
Nothing.
It's not.
Seamless.
Yeah.
Easy.
Right. So, but with your C-suite, how did the conversation go with them? Was there buy-in at the beginning? Did it take some convincing? Were they all financial, so it didn't matter?
Yes, I think that once they realized that there was a way to actually change how we can do this and look at the bigger picture and not just deal with a day-to-day or year-to-year renewal, we could change this. We can make an impact, and change is what we really needed. And they were looking for that, and they were then able to see that this could bring, changes that we needed.
Last question for you. Under ERISA, plan sponsors have fiduciary obligation to their health and welfare plan participants to do the right thing. Duty of loyalty, duty of prudence, monitor your vendors, reasonable fees, all of that. How did that play into your decision making, and how are you actively managing that part of your responsibility as a plan sponsor?
It was very easy. Ethos made this very easy for us. They gave us a checklist of everything that we needed, any templates that we might need. They had the platform to house all the materials if we were ever faced with a lawsuit or if we were ever audited. So these are things that I don't have to worry about either. You guys made it so easy for us to do that. So we're not concerned because we have everything in place.
I swear I didn't ask you to say that, but thank you.
I know.
I appreciate that. And I think the big takeaway is there is so much power in the ERISA fiduciary compliance. And so the CAA of 2021, if you were in the workshop, you know about this, but the Consolidated Appropriations Act of 2021, it was this huge piece of legislation. There's parts of it, 4 parts specifically, that pertain to health plans. One is compensation disclosures for all service providers. Second is gag clause attestation, which if you're a plan sponsor, you probably just did this at the end of the year. You have to go to the CMS website, or somebody did it for you. If somebody else is doing these types of things for you, you want to get a copy, by the way. And you have to go onto CMS and say, I didn't enter into contracts that restrict my access to claims data and quality and cost information, which most contracts in healthcare have those. And then RxDC reporting, that's a ton of different reports on your high cost drugs. Even if you're fully insured, you have a right to that information. So the way I look at the CAA is it's the plan sponsor's most empowering legislation. Like, it will change the face of, it already is, because it was the catalyst for these lawsuits, all these recent lawsuits that are hitting the market. So if you're not familiar with CAA, take that as a takeaway. There's a ton of information on our website and blogs of like actual actions that you can take to use it, but you can use that legislation to demand transparency from your vendors, from your carriers, to get access to claims data. I have a letter that's written by our attorney that we send to carriers. If you'd like a copy of it, feel free to reach out. You're more than I'm happy to share whatever I have. But there's a lot of power that you have to do this, because you might be sitting here thinking like, oh, well, we're fully insured and it's never going to change and I can't get data, I can't take that first step. The market is shifting. The paradigm in employer-sponsored healthcare, like, there's never been a more exciting time to make change. So if you have questions on that, let us know. But we will open up now for Q&A. Ooh, nothing? It was that informative? Okay. Do you have any final thoughts or questions or anything you'd like to share with everybody as a takeaway? Maybe one thing that they could do?
I mean, I really think that even if you are not comfortable going into fully self-funded, to at least go to a level-funded plan to get the data, to understand your costs, to see if there's changes that you can make. I would encourage that. Without data, you can't make strategic decisions.